class titled Case-Based Approach on Plasma Cell Neoplasms, Serum Electrophoresis and Immunofixation by Drs. Uday and Pamela Christoudis on 7th of March. So let's begin. Over to Dr. Krijesh and Dr. Reena.
So good evening. I'll just say a kind of forward, you can say that today we have these cases which have been given to the students, and for the students, many of you are not final year students, but the session is for final year or exam going people. So Dr. Shijesh has given you a nice set of cases which actually just highlights the importance of morphology, where the morphology will actually help you to pinpoint and say, which all investigations need to be done. Now, it's absolutely fine. You wouldn't have probably reported cases of fish analysis, and Dr. Shijesh is the best person to teach you how we need to, interpret and, plan. I think this has been kind of set up in such a way that we have a few cases which are common and also a few cases which are rare, so that you get a spectrum of cases. The rare cases are unlikely to come in your exam, but I thought that we will just discuss something so that you take back something positive from here. Do not feel nervous if you do not know the answers, because this is just a teaching session where we just have to learn from each other. So if you don't know the answers, rather than not wasting time, it'll be nice if you can just say that I don't know this, and probably just we can push ask somebody else to describe. So with that, I'll ask Srijesh to take over and share his screen and also the cases, which is going to be a nice potpourri of cases.
So, Dr. Diksha, can you see my slide?
Yes, sir, I can.
I can hear me. Okay. So, a very good evening to all of you. And as ma'am highlighted, we have given you a set of cases. Some of them are very common, some of them are rare. We will discuss them. So, what my suggestion is, like in real life also, in the exam as well as in real life, we have to make a set of differential diagrams at every stage, starting from the history which the clinician provides us. Then we see the hemogram. Then we have to expand about. We have narrowed down our differential. And then we see the bone marrow. And so this process is a systematic process, and it has to be followed each and every case. I would suggest, even if it's a very simple case, I think we should follow that pattern at every point, from clinical diagnosis, then peripheral blood filling and bone marrow. At every point, you have to narrow down the differentials, and then we advise further ancillary testing. So today's plan is like I'll show the slides, and I will call out the names of one of the residents so they can describe, and then we can rotate among yourself. If you don't know, please just pass on the question to the next person. Okay? So we go to the first case. I will request Dr. Karthika to describe the case scenario. And okay.
Okay, sir. So it's a 36-year-old male with pain in abdomen for 15 days and CKD with nephrotic range proteinuria under evaluation. Bone marrow examination was done. So hemogram is given, and the hemogram appears to be normal.
Right. So my first question is, Dr. Karthika, what are the indications for bone marrow examination in a patient with nephrotic range proteinuria? So you know there are a lot of causes for nephrotic range proteinuria, but you don't do a bone marrow examination in majority of the cases. But here the clinician has advised. So what would be the indication for doing a bone marrow examination in this patient?
So nephrotic range proteinuria, one of the conditions that is multiple myeloma. And in myeloma kidney, there are chances of deposition of amyloid in the bone marrow. So that could be one of the reasons why the physician has asked for a bone marrow examination.
So do you think this is likely to be myeloma, looking at the hemogram findings?
No, and also the other reason could be the gelatinous transformation, which is...
So we'll come to that later. My question is specific. After looking at the hemogram, this patient has just nephrotic range proteinuria and his hemogram is normal. I haven't provided any other details. I hope the rest of the clinical examination, clinical findings are normal. So do you think this is a myeloma? And do you want to equate myeloma with amyloidosis? So you told that, so you actually used a few terms. You told myeloma kidney, then you told amyloidosis. So are they synonymous? And do you think the presence of amyloidosis will qualify for the diagnosis of multiple myeloma?
It's among one of the points in the criteria for myeloma.
Sorry. So next, any other opinion? Mehak, do you have a difference of opinion? Do you think amyloidosis is one of the diagnostic criteria in myeloma?
No, sir, it is not the diagnostic criteria. Diagnostic criteria is chronic renal dysfunction, that is creatinine clearance more than 40 ml per minute.
So I think so. Amyloidosis is not a part of criteria.
No,
so
no, sir.
it was there in the previous WHO. So basically, the revised WHO says amyloidosis is not sufficient unless the patient has CRAB criteria. I'm not going to explain. So unless the patient has CRAB, you cannot diagnose. So amyloidosis you cannot equate with the myeloma. So the patient can have amyloidosis. So unless the CRAB is there, you cannot diagnose him. So basically, your overall your difference is correct. So this patient, this clinician might be suspecting amyloidosis. Any other condition other than amyloidosis can present with nephrotic range proteinuria and hematological disorder. Karthika, Sanobar. So anyone like Purba, Kailash, anyone please. Other than amyloidosis, which other hematological disorder can present with nephrotic range proteinuria? Okay, so basically, anything which amyloidosis is a kind of deposition disease. So you have monoclonal immune deposit disease. It's not amyloidosis; it's a different condition. But it's a monoclonal immune deposit disease. These patients may have a clonal disorder, either plasma cell disorder or another CLPD, which can secrete light chains and then or some protein and they can deposit. So this is one condition. Or you can have a condition which is called monoclonal gammopathy of renal significance. So these patients may also present with some range of proteinuria. So there are different hematological disorders which can present with proteinuria or renal dysfunction. This patient. So that's why this clinician most likely wants to exclude plasma cell dyscrasia. So that's a indication of bone marrow examination in this patient. Again, I'll come to. I think we can go to Sanobar. Can you describe this bone marrow aspirate findings quickly?
It shows the marrow particles which are hypercellular, and in the background there are plasma cells and lymphocytes.
Okay.
Yes, sir.
So do you have particles in any of these slides?
Yes, sir.
Are these particles? Do you think these are particles?
Yes, sir.
So you have to the cellularity. You can say it's a cellular smear, but
Yes,
there are no definite particles. I don't think these are particles. Okay. So maybe it looks like particles in the picture, but these are not particles. The particles are not there. It's better not to comment whether it's a hypercellular or hypocellular or normocellular. You can just say it's a cellular smear. You have enough cells, but it's not the ideal aspirate to comment on the cellularity of the aspirate. So you have okay, it's a cellular smear, and at this power she could see some plasma cells. Okay, and what about this? Okay, we'll go to a little high power. Sanobar, can you describe these things, these images?
So there's
normally in bone marrow. Do you see aspirates?
Yes, sir.
So do you see this kind of material in the bone marrow aspirate frequently? Okay, you first describe this material.
Yes, sir. There first of all there are a lot of plasma cells,
What are
And
plasma cells here? These are not
so
plasma cells. These are erythroid cells.
erythroid precursors,
I
yes,
don't
sir.
think maybe this one is a plasma
This
cell.
one, yes,
More than
sir.
that, I want you to describe this material. So I'm not able to see plasma cells in this field. I can see erythroid precursors, some other neutrophils,
Erythroid precursor.
this
And
material.
myeloid cells, yes, and
I
neutrophils.
want you to describe this. Don't comment directly. Jump and say it's amyloid.
This is a pink amorphous
Yes,
hyaline
pink
material.
amorphous. Okay, mostly acellular, isn't it? The cells are
Acellular.
sticking out the sides. It's a pinkish amorphous and acellular material, isn't it? Okay.
Yes, sir.
And here, what are these cells?
So these ones.
Oh, yeah, these ones. What are these cells? This one, this one, this one, this one.
This one.
Yeah.
These look like plasma cells.
Yes, these are plasma cells. So
Yes,
you have some acellular pinkish material, and
Yes,
you have plasmacytosis. No? And at least in these fields, you have frequent plasma cells, so there is likely there is a plasmacytosis. So you have plasmacytosis, you have pinkish hyaline material. So coming to the biopsy, again, the next person is Purba. Can you describe this refined biopsy?
So the section shows hypocellular marrow with deposition of amorphous pinkish amorphous material
In the
in the intertubular region.
intertubular, basically interstitium, isn't it?
The
So intertubular area as well as basically in the interstitium. So so you have this acellular pinkish material in the interstitium, and it's probably if the overall cellularity appears to be low for the degree of for 48, it appears to be low, and you have this material. And can you comment about the tubercle for 40 years?
So for a 40-year patient, typically appears to be normal.
Normal? Any difference of opinion? Anyone else? I think it's thinned out. It looks like a little thinned out for the 40 years. So basically, it's a little subjective, but I feel they're thinned out. So this is basically the most important finding in this biopsy is the presence of this interstitial material. So coming back to basically, no, Kailash. Kailash, what is the proper diagnosis in this case?
Light chain amyloidosis.
So see, don't jump and say light chain. What is the evidence to say it's a light chain?
Because there are not enough plasma cells.
No. So basically,
There is no.
in pathology, you have to restrict to what the evidence you have. Do you have evidence for light chain here? No, isn't it? Do you have plasmacytosis? Do you have evidence that they are clonal? No. It looks like it's an amyloid.
No.
I think you should restrict that this is likely to be an amyloidosis.
Amyloid.
And since there is a plasmacytosis, it is likely to be primary amyloidosis. Okay, this much you have to restrict your impression to this much. Don't just say that light chain amyloidosis. There is no evidence in the images to say that even it's a myeloma. No? So you don't have evidence for that. It looks like amyloidosis. Since there's a plasmacytosis, it may be a case of primary amyloidosis, but we need to investigate further. So coming back to Karthika, how will you confirm the diagnosis?
Sir, the refined biopsy, we could do congruent in order to confirm the presence of amyloid. Then
Congruent staining, isn't it? So congruent staining followed by completely, if you want to say it's just not congruent staining followed by microscopy under, it's not just like yes, then only it is a complete diagnosis. No? Yeah, then only the statement is complete only if you say like that. So you need a congruent stain. Karthik, do you know any other stain for amyloid?
we can do crystal violet, then thioflavin.
Okay.
And
What happens in PAS?
PAS positive.
Is positive? Is it brightly positive? Mehak?
No, sir. It is weakly positive.
Yeah, it's either absent or it's just a ring positive thing for PAS. What about silver stains? Why do you want to do silver stain? This is a common level, that's why I'm saying. If you do silver stain, what happens to this material? Usually negative, isn't it? And okay, you can also do mass and trichrome, isn't it? And of course, thioflavin. So again, what specific instruction will you give the histopathology technician before doing a congruent stain?
So I don't know.
Okay, Sanobat,
No, sir.
any section, like suppose not only refined biopsy, suppose you have any other tissue section, what specific precaution should be taken before doing a congruent stain? Purba?
So it should be done in a dark.
Dark room.
Dark room, no. Why should it be done in dark room?
Thickness of the section.
Correct, thickness. So what should be the thickness?
It should be a thick section.
It should be thick section, so approximately 8 to 10 microns. Otherwise, it will be difficult to demonstrate this congophilia and the subsequent, that have to be biofilms. Very important. If you don't instruct, if it's done in thin section, it will be no, you can't report it as you won't find that particular staining. Okay. Any fluorescent stain, Kailash?
No idea, sir.
She described about it. You need a fluorescent microscopy, okay, to demonstrate that shift red shift. So you need a fluorescent microscopy for if you are using thioflavin. But most of the labs, usually what we do in kidney biopsy, we do PA stain. We do sometimes we do silver stain, mass and trichrome, and of course congruent. These are the usual stains that are used in the labs. Others for just for theoretical purpose you should know. But in kidney biopsy standard is PAS, mass and trichrome, and of course congruent. Same for bone marrow biopsy also. So other methods, Sharmila, what are the other methods for the demonstration of amyloid? Okay, Karthika, what are other methods for demonstrating amyloid? You're suspecting amyloidosis. Congruent staining you can do. What else can be done on the sections? Anyone? Mehak? You can do immunohistochemistry.
Yes, sir.
AL, you can
Yes,
demonstrate AL or you can demonstrate, you can do IHC. Okay, some of these, but these are available, commercially available, you can do that. Now, if IHC it's not conclusive, what else can be done on sections? Electron microscopy can be done. So this
Yes,
fibers have a particular character in electron microscopy, so you can do electron microscopy. So these things, so there's a cytochemical stain, then you have immunohistochemistry, then the next step is electron microscopy, fine. And what is the gold standard for amyloid typing? Anyone like Sharmila, Kailash, anyone can attempt. What is the gold standard for amyloid typing? There are different types of amyloid. You know that. I'm not going into details. AL amyloidosis, there are so many types of amyloidosis. So what is the gold standard for typing of amyloid?
Spectrometry.
You can attempt. Anyone?
Spectrometry.
No. So it's basically you have to. It's a laser micro dissection followed by mass spectrometry. Okay. So basically what you do is any section you do a congruent staining. So the congophilic areas using laser micro dissection, these areas are cut, and then this tissue is subjected to mass spectrometry. In that, you will be able to identify the kind of protein, okay, whether it's AL or transthyretin or whatever different type of. So this is the gold standard. Now, so you should know, like in difficult cases, this is done, fine. And of course, if it is a genetic disorder, you have to go for a genetic testing. So this is, what is this? Apple green biochemical. This is the classical. This is taken from Ash image bank. So this is the classical. So usually we look for amyloid in the vessels, and of course in bone marrow you can also see in the interstitium. So in this case, you are suspecting a primary amyloidosis. So what further workup will you advise in the bone marrow? Kartika or Mehak?
Sir, immunohistochemistry we can do for
Yes,
the plasma cells.
For plasma cells. What is the purpose of doing that?
Sir, to confirm the clonality of the plasma cells.
Fine. So how do you confirm the clonality of plasma cells by immunohistochemistry?
Sir, it should be either kappa positive or anti-lambda positive.
Okay, so light chain
One
restriction.
of them should be.
Fine.
Yes.
Any other way, indirect methods of saying that these are likely to be abnormal plasma cells? Any other marker? Abundant expression of some markers?
CD56.
Yes, so if the plasma cells are positive for CD56, that suggests they are abnormal. Anything else which can be done in immunohistochemistry? CD117 can be done. Okay, cyclin D1 can be done. Cyclin D1 positive is not very frequent, but if it comes positive on the plasma cells, they suggest these are not confirmatory, but light chain restriction is confirmatory. 56 positivity, 117 positivity, cyclin D1 positivity, and of course light chain restriction. Now suppose you are not very different. They are very scattered plasma cells. You know, let's say 7%, 8%. It's also difficult to demonstrate clonality by immunohistochemistry. So what is the alternate method to prove the clonality of plasma cells in the bone marrow? Sanobar?
So flow
Yes,
cytometry.
flow cytometry. So in flow cytometry, so basically one more question to Sanobar. Can you morphologically suspect whether the plasma cells are clonal or reactive?
Yes, sir.
How? Not saying definitely, at least suspect.
Yes, I suspect.
Yes. Okay, so if the cytosol they are like, they are prominent nucleoli, plasmablastic appearance, and in refined sections, where do you see plasma cells normally? So you see the refined sections, you have different areas, no?
Yes, sir.
You can say the paratrabecular region, perisinusoidal region, perivascular regions, interstitium. So where do you find plasma cells normally?
Sinusoidal.
Perivascular region. So if you have clusters of plasma cells, which is away from the perivascular region, then it's again suggestion. Again, using the words very carefully, it can be a suggestive of abnormal plasma cells. Okay, so morphologically also you can suspect.
I'll just
but
get in
not
here.
very, completely. Okay.
Yeah, actually, two people said sinusoidal, so that would not be correct at all because sinusoidal normally you don't get anything. If you get something in the sinusoid, that would be definitely abnormal. So most of the time, because Dr. Shitesh asked you where do you get them normally, है ना? So sinusoid में generally normally पता भी नहीं चलता sinusoid आपको अगर दिखता भी है तो it will be like empty most of the time, right?
So we have discussed about IHC. Flow cytometry, okay, I mean, so somebody suggested you can do flow cytometry again. In the flow cytometry, based upon light chain restriction or aberrancy of various markers, you can say whether the plasma cells are clonal. And of course, in a ideal setting, you should also do fish testing. This is for prognostication. Okay, I'm not going into details basically, but the complete workup is first you confirm it's an amyloid. Once it is there, second is primary amyloidosis or not, whether the plasma cells are reactive or clonal. If it's clonal, it suggests primary amyloidosis. For that, either use histochemistry or flow cytometry and demonstrate the clonality. Indirect way, you ask a clinician to do a serum protein electrophoresis. If you get a monoclonal protein, again, it suggests the presence of a primary amyloidosis. Still, it's better to confirm the clonality of plasma cells. And once it's confirmed, second is the prognostication. For the prognostication purpose, you have to do fish. For fish, you have to separate the plasma cells, immunomagnetic sorting or some kind of sorting. You separate the plasma cells in the bone marrow, and you do fluorescence hybridization for the markers which are of prognostic importance. Right. So these are the this is the table. So normal plasma cells are usually 19 positive, and they are usually 20 negative, 117 negative, 81 positive. Okay, 28 negative, 200 weak or negative. Okay, but abnormal plasma cells are usually 19 negative. 20 can come. If 20 is expressed, it suggests aberrancy. 117 expression is abnormal. 28 positivity is abnormal. 27 negativity is abnormal. So you should know how to distinguish normal plasma cells from abnormal plasma cells. In the fish, you have to do a set of markers. So you know that IGH, FGFR3, IGH, MAF, MAFB, 70p deletion, and 1Q extra copy. These are associated with poor prognosis that increases the risk of progression and relapse. 414, so 1114 is a standard risk, and they have a specific treatment. Now people say that venetoclax is useful for patients with 1114 transformation. So this is the complete workup in this patient. Okay. Just before completion, other differential diagnosis for a material like this quickly.
So gelatinous transformation of the bone marrow.
The quality is little different. See, this material and this material is usually different. So for the still you should know. Sometimes if this gelatinous material is thicker and more pinkish, you can get, especially in patients who are malnourished, who are on chemotherapy. The plasma cells also will be seen frequently. In that situation, you should not confuse this. So this is one frequent differential because this is more gelatinous transformation is more frequently seen in the amyloid in bone marrow. Also, sometimes the platelet clumps can be confused. This will also look very pinkish. Some metastatic material, neuroblastoma, and that material. Sometimes the fibrotic strands, cartilage in children. All these can be confused with this particular material. So in the particular scenario, you should know all this differential and then proceed further. So this is the gelatinous transformation. This appearance is different from the amyloid. So this is basically hyaluron. So calcium blue will be positive here. So this will not be positive in amyloid. Okay. So this is how you can distinguish. Fine. So we'll move to the. Actually, we took half an hour. We have to be a little quicker. So I would request participants to please. Okay. We have to speed it up. Case 2. Next person, Mehak, you can start.
Yes, sir. 29-year male, severe pallor and bleeding.
Okay. So 29 male with severe pallor and bleeding. Okay. So what are the differential diagnoses in a male with severe pallor and bleeding? Mehak.
Sir, it can be acute promyelocytic APML.
Only by APML or any acute leukemia. So try to keep it
Sir,
differential. Okay. Any acute leukemia can have a person with bleeding,
Yes.
and pallor. Okay. Next.
Yes, sir.
Yes, quickly. So that's why I'm saying before seeing the case, start thinking what are the possible differential diagnoses. So if you don't do that, you might miss some cases. So you have to have a wider view, and you should have a wider differential in the beginning, then narrow down. So one is acute leukemia is frequent. Okay, fine. Any other differential?
GI.
You understand that you can have two situations. The patient have a severe bleeding that is leading to anemia, or there is a disorder which is actually causing both anemia as well as bleeding. You can have two situations. Okay. So severe bleeding leading to anemia, not in this situation, but you should remember that if it's a post surgery, post trauma, some patient with the severe bleeding disorder, all the situation you can have this, so in these cases you can have severe parent in association with bleeding. So in this situation, actually the bleeding is leading to anemia. You can also have a situation where both parent bleeding are due to disorder, where it's basically there's a primary cause causing both. One is acute leukemia. Any other condition?
Sir, platelet disorders.
Fine. So platelet disorder, which condition will you have both bleeding as well as anemia?
ITP, sir.
Okay, severe ITPs. So in that you have bleeding and then you have anemia. Fine. Anything else? Can you have aplastic anemia?
Yes.
You can have anemia and bleeding aplastic anemia, acute leukemias. You can have situation where there's autoimmune hemolytic anemia with thrombocytopenia. So in that you can have anemia because autoimmune hemolysis. Thrombocytopenia is also due to autoimmune hemolysis. Okay, it's called Evans syndrome. So you can have ITP. So this is microangiopathic hemolytic anemia. So in that the bleeding is little uncommon. You don't have severe bleeding, some degree of bleeding, but anemia is usually severe. You have acute leukemia, aplastic anemia. So these are the differential diagnoses which can lead to this this scenario. And Sanoba, can you describe the morphology of this? This is a peripheral feeling of this patient. Can you describe the morphology?
Yes, sir.
Yeah.
So, and these are large cells with irregular nucleus, large irregular nucleus, and having nucleoli and granular basophilic cytoplasm.
Okay, it's irregular, little irregular. How is it placed?
It's placed eccentrically.
Eccentrically. So it's a large cell with eccentrically placed nucleus. Some irregularities there. As you suggested, you have granules. So you have nucleolus. You have granules, and is it basophilic?
Eosinophilic cytoplasm.
Eosinophilic or neither pale basophilic. It's a pale basophilic, somewhat pale basophilic cytoplasm. So if you see these cells, what will you consider? What are these cells? What do they mimic?
They look like promyelocytes.
Sure. Don't be biased. Anyone else? If you see these kind of cells, if I say it's just any marrow, what do they resemble? Are they resembling the classical promyelocytes?
So in which nucleoli are visible, they look like classical.
They are classic. So we come in the thicker slide.
And this one look more like a myelocyte.
Which one?
The one with the yes, sir.
Which one does it resemble myelocytes or this is a promyelocyte? Fine. This looks
Yes,
like a myelocyte. Little hop. Not that one, but still. What about these cells? Do they look promyelocytes or myelocytes?
They look like myelocytes.
Okay. What is this stain?
NPO.
It's a myeloperoxidase stain. So this is a myeloperoxidase stain. So Purba, I want your what are the alternate cytochemical stains for myeloperoxidase?
Sir, we can do Sudan black B.
Right.
We can do
So
PAS.
we say usual alternating most of that because of the problems with MPO stain. So what is the substrate for MPO stain?
Sir, peroxidase in the granules of the promyelocyte.
So what is the substrate which is a chemical which is used in MPO cytochemistry?
Sir, hydrogen peroxide and
Hydrogen peroxide is there of course, but it's not a substrate. It's basically a catalyst like of thing.
So I don't know.
No, MPO stain is done in your lab.
Yes, sir.
So you should know, no? Because what do you add after fixation? What do you add on the cells? It's a benzene or diaminobenzene, isn't it? It's a diaminobenzene. So that's a chromogen. So the myeloperoxidase in the presence of hydrogen peroxide converts diaminobenzene into a colored substrate, isn't it? Then you countersign the chain the cell. So what is the problem of BAB? It's usually not. It's usually not used in many of the labs because it's a carcinogen. That's why many labs use Sudan black B. So Kailash, what is the difference between any idea? What is the difference between the Sudan black and MPO in terms of staining? Kailash, are you there?
Yes, sir.
Yes. Have you any idea? Do you have any idea how is it different? Sudan black B and MPO?
They are both positive for myeloid series.
Correct. Because they're positive. So any difference? Anyone else? Sharmila? So Sudan black B just stains the lipid membrane, which is containing the myeloperoxidase enzyme. So it's not actually specific. So that it's just stains the lipid membrane, which is holding the myeloperoxidase. But the myeloperoxidase cytochemistry is a functional. You see, if the enzyme is not active, the MPO will not be positive. Okay. So Kartika, what are the different methods for demonstrating myeloperoxidase? 3 methods.
So there is a request by one of the attendees to use laser pointer when you're showing images.
Sure, I'll do that. Okay. Kartika, what are the 3 different methods for demonstrating the myeloperoxidase?
Sir, no, I didn't understand the question.
So MPO, you can. So one is the cytochemistry which you can do. So what are the other methods for demonstrating MPO?
sir, ISC and flow cytometry.
Correct. So immunohistochemistry can be used and flow cytometry can also be used. So what is the difference between? So you can take IHC and flow cytometry together and the cytochemistry. What is the difference between these 2 methods?
In flow, in intracytoplasmic granules can also be demonstrated.
So basically, these are antibodies. It's an antibody against the myeloperoxidase antigen, both IHC as well as flow cytometry. It does not indicate whether they are functional or not. Okay, it can be positive, but in cytochemistry, you have a functional method. Okay, whether the myeloperoxidase is present or not, it's active or not. So they are different. So you can have a situation where the flow cytometry is positive, IHC is positive, but in cytochemistry it is negative. It can happen. Okay, so some due to multiple reasons, it can happen. Okay, what are the so Kartika, Mehak, what are the other uses of MPO stain in hematology other than for highlighting the myeloid lineage of blast?
Sir, it can.
Anywhere else? So do you use just only for distinguishing between AL and AML, or do you also use in some other situation? You
Masculine.
can also use in suspected myelodysplastic syndrome to demonstrate MPO negative neutrophils. It's a soft pointer. You see, you have internal control and you have MPO negative neutrophils. In a suspected case, it suggests myelodysplasia. Second, in a child with the immunodeficiency disorder, some neutropenia, you can do MPO stain to demonstrate myeloperoxidase deficiency. Okay, so this is a genetic disorder. Myeloperoxidase deficiency is a genetic disorder. So in all these situations, you can use. In Chidia Higashi, you have the granules, isn't it? With post granules. In that situation, if you really want you can also use MPO to highlight those inclusions. Right? So there are different uses of MPO. It's not just to distinguish acute lymphoid leukemia from myeloid leukemia. You can use MPO in other situations as well. So coming back to the case, so somebody told these look like classical promyelocyte. So is it say these are the classical promyelocyte, isn't it?
Yes, sir.
Yes,
You have heavily granulated, have fatted cells, and you have somewhat this kind of bilobe kind of appearance. So these are the classical promyelocytes. Is it similar to that?
No, sir.
Now they look different. No, these are bigger cells, a little smaller. So this overall is more tilting towards myelocytes and not promyelocytes. What are these? Kailash, what are these?
Which one, sir?
This one? This is a classical promyelocyte. These ones are? These are hypogranular variants. This is a hypogranular promyelocyte which mimic monocytes, isn't it? So they are less granular. Some granules have the, you see the nuclear features. So this is a hypogranular. This is a hypogranular variant of APML. It's a classical APML. So in our case, they are different. So they look more of specific myelocytes. So now do you have a difference? So do you think say APML or is it different, something else? In which other condition you will have predominantly cells which resemble myelocyte in the bone marrow? This patient has a neutropenia or cytopenia, and the bone marrow predominantly the cells are resembling like this, myelocytes or a little bit between monocytes and myelocytes. Maturation arrest. You can have maturation arrest in patients with severe infections. You can have maturation arrest in patients who is on, or basically not maturation arrest, significant left shift and cells something like in patients on GCSF. Right? So don't jump and say that this is a acute promyelocyte leukemia. So basically you should know what is the difference between a promyelocyte and the classical morphology. So you can have variant. There are so many different variant morphologies described in literature. Okay, fine, but still you should know that this is different from the classical acute promyelocytic leukemia. So in this case, APML is of course a differential, but I would also think about a maturation arrest. I would also think about a patient who has received some kind of therapy because of which the morphology is altered. Okay, that's why the history is very important. So what is advice in this patient? How will you confirm? Or what will you advise in this case? You have a marrow like this with predominant cells like this. What will you advise?
Sir,
Coagulation studies.
Who is that? Who is talking? One person. Okay, Kartika. Okay, what will you advise?
Want to flow cytometry?
Okay, flow cytometry. You want to do flow cytometry. Okay. What are the expected findings in flow cytometry? Can you tell me two significant findings you expect in flow cytometry?
If it is APML, then HLA-DR will be negative. CD11B, CD18 will be negative. CD13, CD33 will be likely positive.
Anything else? Much before describing the phenotype? Anyone else? Does any of you see flow plots? You have the opportunity to see flow plots?
CD30.
Anyone else, please? Mehak or
Yes.
do you have flow cytometry?
Yes, sir.
So what is the before describing the phenotype? What is the appearance?
Sir, appearance in APML.
So see this is autofluorescence, brightly autofluorescence. Even if you don't put any antibody, these cells will fluoresce on its own. So they will have this kind of teardrop appearance or whatever. They have a very bright. So this is like CD45 side scatter. These are lymphocytes, monocytes comes up here, and these are this is the progenitor window, and these are granulocytes, isn't it? So in promyelocytes, you have all the cells in this window, and they have a particular appearance like this. So you also have bright autofluorescence, and you have then, as she suggested, these cells will be brightly MPO positive, 13, 33 positive, usually 34 negative. Usually I'm saying, it's not always, usually 34 negative. Almost always HLDR negative. 117 will be positive, again variable. But the most important thing is CD15 will be negative. Okay, so autofluorescence. So the combination of features: autofluorescence, right? MPO positivity, 13, 33 positivity, absence of HLDR and 34, and absence of CD15. So these are the features of acute promyelocytic leukemia. So the expected findings. So you're suspecting acute promyelocytic leukemia. You are doing a flow cytometry. But how will you confirm whether this is a APML or is it a maturation arrest or is it a
Fish. Genetic study.
genetic study? So don't say fish.
Yes.
I don't
Genetic
know.
studies.
Another more genetic studies. You have different methods. So what do you want to demonstrate in this case?
So translocation in chromosome 15, 17.
You want to demonstrate translocation 1570. So what are the different methods to demonstrate translocation 1570?
Sir, PCR,
Okay, PCR you can use. Then
fish.
more commonly used people use.
Karyotype.
Karyotyping. So karyotyping. Okay, that's karyotyping. So karyotyping may not detect many of the cases. If the metaphase is not or if the cryptic. So usually karyotyping, the karyotyping is done, may not detect in all cases. Even if karyotyping done, it's better to confirm that it's PML RR translocation by using either a fish or a reverse transcriptase PCR. So RNA is extracted. So here you need RNA, mRNA, then mRNA is basically the PCR is done on cDNA and then RNA, cDNA, and then you do a PCR. Or you can use a fish. So you can do fish for PML RR to confirm whether this is a acute promyelocytic leukemia or not. So next question is, what will you do in this case if RT-PCR is negative? I'm saying that I suspect APML, but RT-PCR came negative for PML RR. What will you do? What is your differential?
So there are variable RARA translocation. Classical.
Correct. So
Instead of classical, there are other variable RARA translocations. That is 11, 17.
Yes. So you can also do RT-PCR is negative. This is another alternate method. So either if you have like most labs what they do, they send for next generation sequencing. Okay, in that you can identify. If you don't have that facility, but if you have fish in the lab, you can also attempt fish. In fish, you can do PML RARA. So what happens is normally we get two copies of PML, 2 copies of RARA, isn't it? So that's a normal pattern. If there's a translocation, I think I forgot to put okay. If there's a translocation, you get fusion. Okay, but you can have a variant pattern where there are 3 copies of RARA and 2 copies of PML. This is a clue that this is not PML RARA. This is some other variant RARA translocation, and you can also use a RARA break apart fish. Just remember these terms. If you're suspecting a RARA variant translocation, you do a RARA break apart fish. Irrespective of the partner, this fish strategy will identify whether the RARA is translocated or not. So if your PML RARA is negative and RARA translocation is present, that indicates it's a variant RARA translocation. So that can be done. So normally, so this is a normal. So in RARA break apart, fusion is normal and separation is abnormal. In translocation probes, separate signals are normal, fusion is abnormal. Fine. Okay. So in this case, this came out to be positive for RARA, but PML RARA was negative. So as I suggested, there are several variant RARA translocations, like many other. So common ones is STAT RARA, and ZF-RARA, Nuke 98. That's so many partners are there. So some of these, it's important to identify the partner because some of these do not respond to the standard therapy, which is Atratus ATO. Okay, so they might need a AML like chemotherapy. So this case, it's important to identify that this morphology is not classical APML. So when you see this kind of morphology, it's likely to be AML, if the clinical scenario suggests, but it can be a variant RARA. It may show a variant RARA translocation. So this case was given to just show the difference between the classical promyelocyte and variant promyelocytes. Fine. So we need to take into account morphology, immunocytochemistry, flow cytometry, cytogenetics, RT-PCR fish. If RT-PCR is negative, you can use a fish using radar like a pro. And of course, if NGS patient is affordable, we can afford NGS testing. They should go for it to identify the actual partner, because the partner decides whether the patient is likely to respond to the ATA plus ATRO, therapy. Fine. Okay. We move on to the case 3. We can start with Sanobar. Quickly describe the clinical findings. Sanobar, are you there? Sanobar is not there. Purba.
40-year-old male, revived for 10 days, gum and nasal drips, no
Okay.
autopsychomically.
Okay.
Hemogram shows bicytopenia with decreased platelet count and increased blast.
So describe this.
Peripheral smear shows cells with bluish cytoplasm, increased NC ratio.
Normal cells or they are atypical cells?
Atypical cells.
Do they look myeloid or lymphoid?
They look lymphoid.
So do they look mature or immature?
They look immature. Because
So they look immature lymphoid cells. So what would be the DD if you see these kind of cells in the peripheral blood? What are the DD? Differential diagnosis.
Acute leukemias.
If it's not acute leukemia,
Then lymphomas.
normally where do you find these kind of cells? Suppose I say that hemogram is normal, hemoglobin is normal, platelet counts are normal, and you find these kind of scattered cells in the peripheral blood. What will you suspect?
Reactive lymphocytes.
Yeah, virocytes, downy cells sometimes. No? So these are like immunoblastoid like looking cells. So these are frequent. So just don't jump and say they are blast. Okay, but they're looking atypical, they're looking immature. They could be blast, or they could be immunoblasts are also blast actually. They are immature but part of a reactive process. Okay, this is the bone marrow aspirate. People can describe. Now there's no confusion. Doesn't look like a reactive process.
Bone marrow shows large atypical mononuclear cells with large nucleus with nucleolus and regulated cytoplasm.
Regulated? Deeply basophilic cytoplasm.
Regulated
mononuclear cells with deeply basophilic cytoplasm having vacuoles, isn't it? Okay. So this is MPO. What is the interpretation?
MPO is negative, PS
You have internal control which is positive, so these blasts are again another internal control. So blasts are negative. This PS is also
negative.
So these vacuoles are negative for PS. Okay. Okay, fine. Describe the different biopsy findings.
Biopsy shows hypercellular marrow with
Predominantly these kind of atypical cells.
With predominantly atypical cells infiltrating the marrow spaces.
Yes, normal hematopoietic cells are not there. So these cells, what do you think these cells are? They have prominent nucleoli, isn't it?
Yes.
Fine, let's see. Okay. So what is your differential diagnosis, Rupa?
At this stage, Burkitt's lymphoma.
Okay, so you're thinking about a lymphoma. Okay, fine. Burkitt lymphoma, fine. Then this is Burkitt lymphoma, nothing else.
Plasmaplastic lymphoma.
You're thinking about plasmaplastic lymphoma also. So you're thinking about plasmaplastic is some high-grade lymphomas. You can say
High-grade
lymphoma is one of the other high-grade lymphomas, like large B-cell lymphomas and plasmaplastic lymphomas are also considered. Anything else? You're restricted to lymphoma only. Just lymphoma.
Monocytic leukemia.
You think about monocytic leukemia. Okay. Okay. You can think about acute leukemia in general, isn't it? So any acute leukemia and acute leukemias and high-grade lymphomas can be, they are blastoid, they have blastoid cells in aspirate, and they will be large atypical cells in the biopsy. So both, they are different. So you should consider both acute leukemias as well as lymphoma in this case. So the presence of vacuoles, you know that many acute leukemias can have vacuoles in the cytoplasm. Even BALs can have vacuoles. You can have monocytic leukemias with vacuoles. You can have erythroid leukemias with vacuoles. So acute leukemias, so the vacuoles just don't take it to Burkitt lymphoma. You have to keep your options open. Fine. So what will you advise? The next question. Sanobar is not there.
Yes, sir. Yes,
Sanobar, so what will you do? So you have a differential of both leukemia and lymphoma in this case. What will you advise?
sir, flow.
Directly flow. So many labs don't have flow. More easily available. Yes, of course, if you have flow, fine, you can do flow. If flow is not there,
I'd say.
okay.
First of all,
Suppose we have-
cytochemical stain. We can do cytochemical stain first.
we have done, no? Which cytochemical extra cytochemical stain you want? We have an MPO, we have an PS. What else you want? Yes, of course, one more is there.
So dark black P.
So what will you have?
Non-specific esterase NSC.
Okay, so I don't know how many labs are, is it widely available or not. But
So
any
after
stain in
that,
Burkitt lymphoma, any other cytochemical stain which will help in Burkitt lymphoma? What are these vacuoles in Burkitt lymphoma? How is it different from the vacuoles of BALL? These vacuoles contain lipid in Burkitt lymphoma, and whether they are containing glycogen in BALL. So basically, in BALLs, acute leukemias, they will be positive for PS, but they will be positive for oil red or other lipid stains in Burkitt lymphoma. Right? So you can also use. So okay, of course. So now, if you have flow cytometer, which panel will you advise in this case? Anyone else?
Sir, we will apply B-cell marker.
CD, CD 19, 20.
packs.
So Kailash is speaking. So Kailash, you can say.
CD 19, CD 20, CD
Okay,
22.
don't enumerate all the markers. You need B-cell markers. Fine. Then
We can also do CD 34 and TDT.
so you need some markers for immaturity. So because you're suspecting a leukemia,
Then
you need
So minor center
if
marker.
it is Burkitt lymphoma, then CD 34 and TDT marker will be negative.
fine. So okay, so you need lineage specific markers. You need B markers for B. You need markers for T. You need markers for myeloid because we have also kept other acute MPO negative myeloid leukemias as a differential. Of course, so you have to exclude whether it's acute leukemia or it's a lymphoma. So 34 and TDT you told. Something else is required to support a diagnosis of lymphoma.
Germinal center marks.
Yeah, which marker?
So BCL6. BCL6.
Which is not frequently done.
CD10.
CD10 is it specific for lymphoma? Can you get CD10 in leukemias? You get no. Most of the
Yes,
BMs are CD10 positive. Okay, so CD10 may not help. Anything else which will help to support diagnosis of lymphoma or leukemia? So of course, 34 negativity, TDT, negativity favors CD45. What happens to CD45 in acute leukemia and lymphomas?
So 45 is positive in lymphomas.
Positive is not sufficient. Brightly positive or dimly positive
Brightly positive.
in leukemias.
Leukemias, yes.
Leukemias are usually CD45 dim to negative. Lymphomas, most of lymphomas, I will not say all, most of lymphomas are usually CD45 bright. Many high-grade lymphomas can be CD45 dim, it's fine. But another thing is surface light chain markers, so kappa and lambda. Okay, so these are usually positive lymphomas. Surface light chains are usually negative in leukemias. Surface immunoglobulins, IgM, IgG, these are positive in lymphomas. They are usually negative in leukemias. Right. So you need lineage-specific markers, you need maturity markers. You need suppose you're suspecting I'm not going to T, but if you're suspecting mature B-cell lymphomas, you need surface light chains as well as surface immunoglobulins. Right. So if you don't have a flow cytometer, you have to go for immunohistochemistry. So what are the markers which will you order for immunohistochemistry? Sharmila. Sharmila, are you there? No. Kartika, what panel will you order if you're suspecting, in this case, in IHC?
First, B cell markers, the germinal center markers, Chi67. Then
So please tell me, can you enumerate the markers?
B cell markers which include CD19, CD20.
IHC, you do CD19 by IHC? Usually not. You do CD20. Okay, you may CD79 is available. Okay, fine. Okay, CD20 is done. Then you don't want to do T. You are just directly concluding that it's a B. So you have to use a combination of CD20, T cell marker CD3, then CD45 is required. Then you do CD10. Usually in the panel, you need a BCL2, BCL6, MIC, K67. So you always do a panel, or you go by stepwise panel. You first see whether it's a B or T. If it's a B, then you go for germinal cell markers and K67. So you can use different approach depending upon the ease of availability and the cost constraints and depending upon the policies in your lab. Fine. Mehak, can you just summarize the findings? I don't want you to go in detail. Just summarize the findings in the flow cytometry and.
Sir, it is CD45 positive, CD19 positive, CD5 and 23 negative, CD79B positive, CD20 positive, CD200 negative, 34 negative.
Okay.
Sir, CD10 negative.
10 positive.
Positive, sorry, sir. CD10 is positive, and sir, after that CD45 is positive.
What is this?
Yes, sir.
What about this?
Sir, it is kappa positive.
Positive.
And lambda
negative. Fine.
Negative. Yes, sir.
This one.
This one, sir, IgM positive. IgG negative.
Okay.
Negative.
Fine. So what is your what is your impression after seeing the flow cytometry?
Sir, it is a B cell neoplasm.
So it's a B cell neoplasm. Okay. Is it mature or immature?
So can I see it? Yes.
Is it mature or immature?
Sir, it is mature.
Why?
Because CD34 is negative.
Then
I
told you 45 bright.
Bright positive.
34 negative.
Negative.
And kappa positive.
Positive. Yes.
20 is also bright. So 20 is usually more heterogeneous in immature. You can have even BLS with 20 positivity, but majority of the BLS or immature neoplasms are usually at 20 more heterogeneous. You have so all these are prevalent. Bright 45, bright 20, kappa positivity, and absence of CD34, and of course presence of surface immunoglobulin. All these favors a mature B cell neoplasm. And so what will you? So what is the? So it's a CD10 positive, kappa restricted mature B cell neoplasm. What are the differential diagnoses for CD10 positive mature B cell neoplasms? At least two differentials.
Diffuse large B cell lymphoma.
And suppose the morphology you don't know. It's a small lymphocytes. Then
mental cell lymphoma.
Is it 10 positive? Mental?
No, cycling even.
5 positive. There are mental lymphomas are 5 right. No? It's a 10 positive mature B cell neoplasm. Follicular lymphoma. The most important differential diagnosis is small. It's a follicular lymphoma. If they are large blastoid cells, then it's a DLBCL. Okay. So now what will you do? So now you have a large cell lymphoma. You have demonstrated that it's a CD10 positive mature B cell neoplasm. How will you confirm? Are you sure this is Burkitt lymphoma? Now after seeing there are everything is supporting it's a Burkitt lymphoma. But how will you confirm it's a Burkitt lymphoma?
By genetic studies.
What will you do?
Sir, fish.
Yes. What is that?
Fish, sir, translocation 814.
Okay, so you have to do a fish to demonstrate which translocation?
Sir, 814.
Not just 814, there are other 814 IGH MIC.
Sir, translocation.
Kappa with IG lambda. So basically, what is the common factor, common gene?
Sir, c-MYC.
c-MYC. So c-MYC, you have to demonstrate c-MYC translocation. So again, you can use either a translocation top or a breakup top. So normally in MYC breakup you get two fused signals like this. In this case, we got one fusion, one green, one orange. So this is indicative of MYC translocation. Same, if you use IGH breakup top, you got one fusion, one green. So this patient is having a MYC translocation. Now my question to the next person is, Purva. So what are the hematological neoplasms with MYC rearrangement?
Burkitt lymphoma. Yeah.
Yes.
Burkitt lymphoma.
So MYC rearrangement means Burkitt lymphoma, or can be something else? So you can have, it's not like, MYC rearrangement is not equivalent to Burkitt lymphoma. Okay.
DLBCL.
Yes, you can have other high-grade lymphoma. DLBCLs can have, so MYC, isolated MYC rearranged DLBCL. You can have MYC rearrangement as a part of double hit lymphomas, isn't it? In double hit lymphoma, what is the recent definition of double hit lymphoma? Anyone? Latest definition. MYC and
BCL2.
You need BCL2. BCL6 is not sufficient. MYC plus BCL2 plus or minus BCL6. So the term is high-grade B-cell lymphoma with MYC and BCL2 and or BCL6 rearrangement. So you have to do BCL2 as well as BCL6 fish. So irrespective of the morphology, you can have I'm not going to the. So you can also see MYC rearrangement BALS. You can see MYC rearrangements in multiple myeloma. So this is a flowchart from the latest WHO. If you have a large cell morphology, MYC rearrangement, you see BCL2 rearrangement, then it's a double hit lymphoma. If it's not BCL rearrangement, it's a DLBCL. Now Burkitt like morphology, isolated MYC rearrangement, Burkitt lymphoma. But along with MYC rearrangement, if you get BCL2 rearrangement, again it goes to the high-grade B-cell lymphoma with both MYC and BCL2 rearrangement. So you should know this. So ultimately, what I want to highlight is you have to go in stepwise manner. Morphology is important. Cytochemical stains are helpful many times. Flow cytometry or immunohistochemistry to demonstrate the immunophenotype. Finally, if you have fish, you can confirm. But mind that MYC rearrangements are not exclusive for Burkitt lymphoma. They can be seen in DLBCLs, especially double hit lymphomas. They can be seen in BL. Now, if those who are interested, you should read how to distinguish. If the TDT is positive, there are some new entities which are coming. If TDT is positive and MYC rearrangement is there, people are saying it's a different entity. And of course, it can be seen in multiple myeloma as well. So plasmablastic lymphomas can show MYC rearrangement. So just remember that. Okay, fine. So MYC rearrangement is not just exclusive for Burkitt lymphoma. Case 4. Kailash.
62-year-old male present with generalized weakness, easy bruisability for 20 days, fever 1 to 2 days, history of 1 unit PRBC transfusion. On examination, mild pallor, bony tenderness, purpura, and ecchymosis. No history of comorbidities, moderate splenomegaly, no lymphadenopathy.
Okay.
Uh,
And what's the hemogram showing?
Hemogram showing anemia with the increase in TLC.
Okay, one word if you want to say the hemogram findings, what will you say? There is
Pancytopenia.
pancytopenia. So anemia, thrombocytopenia, and leukopenia. So this is pancytopenia. So the patient with pallor, bony tenderness, is to some bleeding manifestations, moderate splenomegaly, and the hemogram is showing pancytopenia. So what is the differential when you have a case with the
Was not showing pancytopenia.
sorry, This leukocytosis with bicytopenia and leukocytosis. Sorry, I'm extremely sorry. So there is anemia, there is thrombocytopenia, and there is leukocytosis. So leukocytosis with moderate splenomegaly in adult. What is your differential?
So CML, ALL, then
ALL.
the infection, leishmaniasis,
Sometimes.
sarcoidosis.
There are many differential diagnosis. Okay. So for CML,
Yes,
usually
leishmaniasis should not come there because usually you get pancytopenia, and that leukocytosis is very unusual for Kala-azar or leishmaniasis.
even most common CMLs, hemoglobin and platelets are usually preserved. Only when they progress, their hemoglobin starts going down in the platelet. Usually, like majority of the cases, CML also hemoglobin and TLC, hemoglobin platelets are usually normal. In fact, the platelet count is on the higher side in CML. Okay, so any other differential leukocytosis with the moderate splenomegaly. CML, of course, if it's in the progression, you can have anything else. Hematology causes, if I'm more specific.
Hemolytic anemia.
Hemolytic anemia, leukocytosis. Okay, you can have sometimes not frequent. Anything is more common. Sharmila with the
So, sir, Sharmila is not there.
Kartika.
Myelofibrosis.
See, you have to know now. Then only you have suspected.
Malaria.
Okay, some hematological neoplasms. You think leukocytosis with moderate splenomegaly.
Sir, MDS.
MDS, you have leukocytosis in MDS? No. MPN, generally, MPN, you say MPN. Other than CML, other MPNs can present leukocytosis and moderate splenomegaly. Okay. You can have many CLPDs, isn't it? You can have CLL with this picture. You can have leukocytosis, moderate splenomegaly. You can have other chronic lymphoproliferative disorders, isn't it? Okay. Now, Kailash, I will come back to you. Just describe the morphology of the peripheral blood.
In this peripheral blood smear, we can see increase in WBC counts.
It is leukocytosis.
Leukocytosis.
Predominantly.
The cells are mononuclear cells, which are larger than RBCs.
Okay, slightly larger. Okay, there are mononuclear cells. That doesn't look like granulocytes, predominantly mononuclear cells. Leukocytosis. Okay, we'll go to high power. For time being, actually, this is leukocytosis, predominantly mononuclear cells. Right. So now again, so peripheral lymphocytosis plus lymphadenopathy with or without splenomegaly in adult. Just think. I want you to think. A patient with peripheral lymphocytosis with lymphadenopathy, splenomegaly present or absent, what will be your differential?
Lymphomas.
Lymphomas. DLBCL usually present like that? 10% leukemia,
Yes, sir.
percentage of DLBC, but more common things. Which is the commonest one which present like this? CLL, isn't it?
CLL.
CLL. Yeah, you can have, sometimes leukemia presentations of other CLPs, like, follicular lymphomas, DLBCL, everything can come like that, but most commonly it's a CLL which present like this, isn't it? Now, I'm going to other situation where there is a peripheral lymphocytosis and splenomegaly, but there is no lymphadenopathy on clinical examination as well as imaging. Then what will you think? Kartika? You have a splenomegaly, you have lymphocytosis, but no lymphadenopathy.
Hairy cell leukemia.
Hairy cell leukemia, usually classical or something else? Variants.
No, variant.
Hairy cell leukemia is usually classical, it comes with pancytopenias. So you usually hairy cell leukemia variants. So if you say hairy cell leukemia variant, what is the closest differential of hairy cell leukemia variant?
Splenic marginal zone
Correct.
lymphomas.
Splenic marginal zone. These are the two important differentials. We also get sometimes lymphoplasmacytic lymphomas with splenomegaly and some degree of lymphocytosis. They may not have lymphomas, but the commonest ones are hairy cell leukemia variant and this one. Any other? If I say it's a little high grade or more acute presentation, and not B. Is there any other PCLPDs which can present with peripheral lymphocytosis and moderate to massive splenomegaly? No lymphadenopathy. T cell lymphoproliferative disorder. Anything else? Any?
NK cell.
No, it may have, but more common. Hepatocytic T cell lymphomas. Okay, hepatocytic T cell lymphomas presents with, they can present. I will not say that always. Sometimes they may not have lymphocytosis. This is another differential. If a patient with some degree of lymphocytosis, moderate to massive splenomegaly, no lymphadenopathy, HSPL also should be suspected. Right. Okay. So now, Kailash, so now you describe this morphology in higher power.
In this microphotograph, we can see cells with the high NC ratio and fine delicate chromatin in their nucleus, and we can also appreciate nucleolus in
Some of them they have
nucleus.
nucleolus. Right. Okay. So they are much bigger cells. But do you think blast?
Blast.
Not sure. Okay. In real life, sometimes it's difficult. Okay, they look a little immature, but not sure that they're blast or not. Again, now do you think they're blast? There's a suspicion again, isn't it? It can be blast. Okay, we're not sure. Again, okay. So there are some variation in the size. They have central nucleolus, but not really immature, not really blastoid looking. Okay. So, Kailash, or basically you can go back to Kartika. Just name some CLPDs, some BCLPDs, and name some TCLPDs. Quickly. BCLPDs. Follicular lymphomas, mantle cell lymphomas, TCLPDs. Large granular lymphocyte leukemias, NK cell leukemias. Okay. So somebody wants, Mehak, can you tell me what is the salient psychological feature of CLL cells?
Sir, they are the mature lymphocytes, and some smudge cells may be present on the peripheral blood.
Okay, what about the nuclear feature of CLL cells?
Sir, dense clumped chromatin with little cytoplasm, little or no cytoplasm.
This particular name given for that. Saucer ball like that. Okay, then you have smudge cells. You can have some prolymphocytes. Okay. Mantle cell lymphoma, again, Mehak. What's the
Sir,
psychological characteristic?
I don't know.
Anyone else? Sanogar, what is the psychological feature of mantle cell? Cleaved cells? Cleaved, welcome to the photograph. Okay. Follicular lymphoma also will be cleaved cells.
Cleaved cells.
They're cleaved cells. What about marginal zone lymphomas?
Carrot.
So marginal zone lymphomas will have a, okay, I think I'll come to the hairy cell leukemia. They will have
So
hairy
it has hair projections.
Okay, so basically you should know that many of these have classical morphology. So this is hairy cell leukemia with hairy projections. Okay, so their nucleus also will be little groups. They call uniform nucleus, isn't it? So hairy projections. Marginal zone lymphoma can have a different kind of cells. You can have small mature lymphocytes. You will have some cleaved cells. There are centrocyte-like cells. You have some plasmacytoid lymphocytes. You have some monocytoid lymphocytes. And of course, sometimes you will get cells with polar villi. Right? We have, you know that marginal zone lymphoma can have polar villi. So if you see a wide variety of cells, small mature lymphocytes, cleaved cells, plasmacytoid lymphocytes, monocytoid lymphocytes, and of course some cells with polar villi, then you should start suspecting marginal zone lymphoma. CLS cells, as described, plum chromatin, some prolymphocytes can be seen. Prolymphocyte leukemia, predominantly cells with prolymphocytes. With larger cells, centrally placed nucleolus. These are prolymphocyte leukemias. Cleaved cells, you know, follicular lymphomas, little larger, mantle cell lymphomas. You start seeing blastoid cells. Think about DLBCL, of course, leukemia, DLBCLs, many vacuoles are there, bucket lymphomas, hepatocytic T cell lymphomas, blastoid variant. They can also show blastoid appearance. Intravascular large cell lymphomas also will have blastoid appearance. This is the typical hepatocytic T cell lymphoma, intermediate size cells, some nucleolus, and large granular lymphocyte leukemias, and NK cell leukemias will have excentrically placed nucleus with granules in the cytoplasm. So now onwards, pay attention to the nucleus, to the cytological features. From that, you can suspect what kind of CFPD is it. Okay, fine. And of course, you know that other T cell lymphomas will have flower-shaped nucleus and so and so. Okay, so now you are suspecting you have some atypical cells, and again, what investigation will you advise? Tell us.
We will do staining MPO plus
Okay, MPO plus. Okay, you will have suspicion of leukemia. MPO plus everything is negative now.
NSCs.
No, not available. Next.
Next, we'll do immunophenotyping.
Phenotyping. You can say better immunophenotyping depending on what is available there. If you have ISC, you go for ISC. You have flow cytometry, you go for flow cytometry. Karthika, can you describe the flow cytometry findings in this case?
CD7 positive.
Cells were treated. You have to say that here they are starting with CD7 positive events. Before that, I can say that the B cells are only 1.8%, and there were no clone restrictions. CD34 positive, just 0.2%. Okay, but you started. Now I'm just showing what is significant here. CD7 positive events were treated, and what you found.
Then CD5 it's positive, CD3 negative.
You just focus on these red cells. Okay. Okay, you have these green cells are dividing between 4 and 8. But what about this red population?
CD5
Negative.
negative and CD3 is
positive.
positive.
4, 8.
CD4 red one is positive.
Negative. Okay, these are the positive cells. CD4 and CD8 are negative. T cell receptor alpha beta is negative. T cell receptor gamma delta is positive. CD2 is positive. Some heterogeneous 57, 56 is negative. So after seeing the flow cytometry, what do you think? So you have series that T cells, CD7 positive, CD5 is negative, CD3 is positive, 4, 8 will negative. The surface with gamma delta T cell receptor is positive. What is your diagnosis? You have large cells.
Hepatosphere.
So you should suspect hepatosphere T cell lymphoma. So do you think gamma delta T cell receptor expression is exclusive for gamma delta T cell lymphoma, or can it be seen some other lymphoproliferative disorders? Okay, so you can have 3 degrees, of course. Hepatosphere T cell lymphoma, gamma delta type, TALL gamma delta type. You should just know about this entity. There's a TALL gamma delta type where it can resemble hepatosphere T cell lymphoma. The immaturity markers may not be there. Okay, but here there are some odd points. I will come to that. TLGLs gamma delta type is also there, but the morphology is not like LGL. Okay, so the most likely diagnosis is hepatosphere T cell lymphoma. What do you expect? What do you expect in refined biopsy in the case of hepatosphere T cell lymphoma?
Sir, it is hypercellular bone marrow biopsy.
Okay,
Which shows,
what will you look for if you are suspecting a hepatosphere T cell lymphoma?
sir, large lymphocytes, predominant of the lymphoid population.
Okay, so what is the? Can you see what is highlighted here? What is this?
Minus.
Sinus. So it's a sinus, it's inside the sinus. So you have to look for sinusoidal infiltrate in a case of hepatosphere. This is another sinus which is packed with these cells. So unless you look for it, you will not find. So suppose it's very difficult to identify by HNE, what will you do? You will have to do CD3 immunostain. So you can see that the sinusoidal infiltrate will be highlighted by immunohistochemistry. Right? So if you're suspecting hepatosphere T cell lymphoma, you have to do a immunohistochemistry for CD3. Okay. Suppose you don't see sinusoidal infiltrate, you know any, you have to also do TDT and CD34 because as I suggested, especially if the sinusoidal infiltrate is not there, do a TDT and 34 to exclude a TAL gamma delta type. Now both are negative. Do you know any characteristic cytogenetic finding in a hepatosphere T cell lymphoma? Okay. Isochromosome 7q. Do cytogenetics, you find isochromosome 7q. In fish, if you do a single 7 substitution in NDS, what will happen is two signals will be there from centromere, and there will be 3 signals from the QR because there's an isochromosome 7. So that is an indirect way of showing the isochromosome 7q. Fine. So these are the 3 different diagnoses: hepatosphere T cell lymphoma, TLL, and TLGL. So morphology is important, the sinusoidal infiltrate is important, the immunophenotype is important, and ultimately the isochromosome 7q can be done. Okay. So at this point, I think I would like to ask. I think Diksha and Reena, should we go ahead, or we'll just quickly, because I think it's already.
You can just show the cases rather than ask because we are already at.
Yes, I'll just quickly go to the next 2 cases. Fine. I think fine. Okay. So this patient person is 48-year-old female with weakness and EC fatigability and some multiple lymphadenopathies there and massive splenomegaly is present. You see this peripheral blood filling is showing lymphocytosis. Okay, and you see there are myelocytes. You have metamyelocytes. Okay, and hyper you can see that there is some eosinophils, myelocytes, nucleated red cells. So basically there is a leukoerythroblastic picture. Somebody wants to start just quickly. What is the morphological diagnosis? What is the morphological diagnosis of this male?
Sir, chronic myeloproliferative neoplasm.
Most likely.
Most likely chronic eosinophilic leukemia.
I want to say chronic. This is you see
Chronic
chronic myeloleukemia. No,
chronic myeloid.
that should be the commonest reading in this case. How often you see CEL? There are eosinophils, but in CML also you find excess of eosinophils, and you can have basophilia. You will have basophilia. So the common differential you should think that basically, it's likely to be CML. Okay.
CML.
Okay. So this patient also. So this marrow is hypercellular. Again, you see the left shift in the myeloid series because we have a lot of myelocytes and metamyelocytes, some eosinophilic precursors. The biopsy is packed. It's a hypercellular marrow, okay, and it predominates of myeloid precursors. You can see some megakaryocytes, they are not very much increased, but of course they are there. Fine, it's high power. You have excess of eosinophils and precursors. So the most likely diagnosis in a clinical scenario, you should think about CML. Which any cytochemical stain you wish to do if you're suspecting CML? Rafika, which cytochemical stain will you advise?
No.
Also called glucoside alkaline phosphatase. What happens to glucoside alkaline phosphatase in CML? Reduced, isn't it? Will be reduced. Okay. So after NAB, you are suspecting, what will you advise? You will advise cytogenetics, RT-PCR or fish. Okay. So this is a neutrophil alkaline phosphatase. So the fish, this is a normal pattern. So 2 signals from the ABL1 and 2 signals from the BCR. So if there is a translocation, you get 2 fusions. So balanced translocation, you get 2 fusions. One is a BCR ABL on 22 and the other is ABL BCR on the chromosome 9. So balanced translocation, these are from the normal BCR and ABL, and these 2 fusions are the 2 derivatives. Balanced translocation. Suppose, so if the BCR ABL comes positive, the diagnosis is straightforward. Fine, this is BCR ABL positive, 1 positive CML. Now, suppose the BCR ABL1 comes negative, then you should think about BCR ABL1 negative, other myeloproliferative neoplasms. So there are many other disorders which can mimic CML, which includes cellular phase of progressive myelofibrosis, PMF, primary myelofibrosis. The cellular phase, early phase, it can mimic chronic myeloid leukemia. There are many other myeloproliferative neoplasms which can mimic CML. So first thing is always exclude BCR ABL1. After that, you can look for other translocations and other mutations. Fine. I'm not going into details. So in this case, actually BCR ABL came negative. And this, I told you in the history, this patient had generalized lymphadenopathy with massive splenomegaly. FNAC from the lymph node was reported as lymphoblastic lymphoma. So whenever you have lymphoblastic lymphoma in the lymph node and you have a myeloproliferative neoplasm in the bone marrow, then you should think about MPN in blast crisis, or there are other lymphoid and myeloid neoplasms with various translocations. You know that PDGFR AB, FGFR1, JAK2, all these neoplasms can present with the divergent differentiation. You can have a blast crisis on some side, you can have a myeloid neoplasm on some other side. So all these comes at a later stage. The most common diagnosis is CML, and in this case, it can be CML blast crisis. Now BCR came negative. You look for other translocations by either cytogenetics, or if you have the facility, you have the patient affordable, send for NGS. It should include the fusion panel as well as the mutations. Right. So this was the case of FGFR1 translocated myeloid neoplasm. And going into detail, the case 6 is a 36-year-old male with weakness and paraparesis and epidural mass. So whenever you have epidural mass and this patient is having a leukocytosis, so again, if you have epidural mass with leukocytosis, so it can be infection. You know, it can be an abscess and the leukocytosis may be a leukemia reaction, or it may be metastasis and the leukocytosis can be a paraneoplastic phenomenon. Okay, or it can be a myeloid sarcoma with the MPN. So these are different diagnoses which you should consider. So this case, I showed you, this patient had peripheral blood eosinophilia. Majority of the leukocytes were eosinophils, and the bone marrow aspect, you can see that a lot of eosinophilic precursors left shift, excess of eosinophils and eosinophilic precursors. So in this case, again, the peripheral blood picture is not like a usual CML or other myelophilia, just showing a eosinophilia, and the bone marrow is hypercellular with excess of eosinophils and eosinophilic precursors. In this case, you may suspect a clonal eosinophilia or eosinophilic leukemia, and again, the marrow is packed. You have eosinophils and eosinophilic precursors. So definition of eosinophilia is more than 500. Absolute eosinophilic count more than 500 per microliter is eosinophilia. Hypereosinophilia is more than 1500. Is hypereosinophilia. Hypereosinophilic syndrome is hypereosinophilia plus an organ dysfunction. Okay, either lung infiltrate or cardiac infiltrate from neuropathies or something else. So if you have an organ dysfunction with hypereosinophilic, it's hypereosinophilic syndrome. So this case, does it qualify for hypereosinophilic syndrome? Yes, because patients have an epidural mass and patients having paraparesis, it's likely hypereosinophilic syndrome. Now the next question is it a reactive or is it a neoplastic, isn't it? So fine. So whenever there are certain morphological features, clinical morphological features, which will help to distinguish reactive from a clonal process, neoplastic process. For example, if you have some left shift in the peripheral blood, it will favor a neoplastic process, not completely. Second is the patient is having a significant lymphadenopathy or hepatosplenomegaly, it supports a neoplastic eosinophilia. Third, if the patient is having a high vitamin B12 levels or high LDH, it can support. Fourth, in the bone marrow, you can have mast cell tryptase. If there are clusters of these are mast cell tryptase immunohistochemistry. If you have clusters of mast cells, it favors a neoplastic process. If you have fibrosis in the bone marrow, it will favor a neoplastic process. All these only favors. Ultimately, you have to prove it. So I'll just repeat: reactive versus neoplastic, clinical history. Okay, some presence of splenomegaly or significant lymphadenopathy in bone marrow, in the peripheral presence of left shift, the presence of mastocytosis in bone marrow or fibrosis. All these favors in neoplastic process. If you have high tryptase, again it also favors. So there's a lot of clonal markers which will help distinguish clonal from reactive process. You need a combination of cytogenetics plus RT-PCR plus or minus fish, or if you can do NGS or fusion panel plus mutations. That will identify the. So the most common, one of the commonest, translocation associated with eosinophilia is PDGFR, FIP1L1. So what happens? So PDGFR, FIP1L1, usually you can use a fish or you can use RT-PCR. In fish, what is done is there are 3 probes. One is for FIP1L1, other is for CHIK2. The CHIK2 gene sits between the FIP1L1 and the PDGFR. So what is happening is this CHIK2 gene get deleted and the FIP1L1 comes close to the PDGFR. So in fish, you can see that there are 2 signals from the FIP1L1. You have 2 signals from the PDGFR, but the CHIK2 you have only one red signal. So that means CHIK2 is deleted. The deletion of CHIK2 is an indirect indicator of FIP1L1 PDGFR translocation. So this was a case of FIP1L1 PDGFR rearranged eosinophilia. So that's about the and last case I discussed this one. So this is a 72-year-old female, PLHA, you know the full form, and this patient had lytic lesions. The patient had cytopenias, bone marrow was aparticulate, and you can see an occasional. What is this cell? Anyone in that
Mast
cell?
cell.
Mast cell. So this is a mast cell. And in the biopsy, high power, you can see that spindle cells. A lot of spindle cells. Okay, there are clusters of spindle cells in the biopsy, and there are some lymphoid aggregates. So whenever you see spindle cells in the bone marrow, so in this patient, of course, is an HIV positive. So you know that the mycobacterial infections, typical mycobacterial infection, can present with spindle cell lesion. Whether the lymph node is it in extra lymph node sites, even bone marrow, you should think about a mycobacterial infection. It's HIV positive patient, spindle lesion, always AFB, exclude whether it's a mycobacterial infection or not. Kaposi sarcoma, because it's another differentiation, spindle lesion in HIV positive patient. When several sarcomas can present with spindle cell lesion in the bone marrow, but in a common scenario, you should always think about mastocytosis. Spindle cell lesion in bone marrow, think about mastocytosis. Of course, other rare diseases are there. So this is a site, this is from Nash image bag, a case of Kaposi sarcoma infiltrating the bone marrow, and HHV8 is the marker for Kaposi sarcoma. So they are very rare, just. But otherwise, in this case, we have to do FBMPAs to exclude infections. Procytometry you can do because lytic lesions are there. You have to exclude multiple myeloma. Mast cells are there. You have to confirm whether the mast cells are abnormal or not. And of course, IHC you can do. So we have done HHV8 plus negative. This is a tryptase. Tryptase is highlighting all the mast cells. So this was a case of. We can also do if tryptase is not available. CD117 can be done. CD117 will be likely positive in mast cells. Okay. 2 and 25 are abundantly expressed in abnormal mast cells, so CD25 was also positive. CD30 is another marker. If 30 is positive mast cells, that indicates that they are abnormal mast cells and not reactive mast cells. This was the case of systemic mastocytosis. Fine. So at this point, I think I'll stop at this point. And I think, ma'am, you can make some concluding remarks. Moderators, if you have some comments, please.
Thanks a lot, Srijesh. I think you have shown a good spectrum of the a lot of disorders which are predominantly malignancies that we have seen today. And I think for the residents, mainly whenever you look at the peripheral smear and you are a bit undecided about whether this is going to be a benign reactive condition or blasts which are going to be taking you towards a malignancy, then there are two terms we sometimes use. Sometimes we say transformed lymphocytes. When we think of viral infections, they do look blastoid at times, but then we usually think of reactive conditions when we're saying that. When you say atypical lymphoid cells, at that time probably you are trying to connotate that this is looking like a malignancy, but you don't know what it is. Sometimes that is also a possibility. So I think we have seen a lot of investigations are required when we have a differential diagnosis, which is a long differential diagnosis, and each case will require that much of workup to come to a definitive diagnosis. So I think Dr. Srijesh has shown you a spectrum of disorders which is there, and if you all have any questions, anything specific, you all can you're free to ask, and then I think Disha can take over.
Sir, the attendees want to know the exact diagnosis for the last case 7.
Actually, I skipped case 7 and took case 8. So case 7 was plasmablastic lymphoma. Actually, I wish to show that it's a high-grade lymphoma. Whenever you get a high-grade morphology, you should think about leukemias, high-grade lymphomas, metastasis, and of course plasmablastic lymphomas, erythroleukemias. This can have that kind of morphology. So plasmablastic lymphoma is sometimes a difficult diagnosis. If you think about it, because there will be 20 negative, and so I didn't because okay, because already it's like 2 hours on another 40 minutes we have discussed. It was a plasmablastic lymphoma.
Thank you, sir. Sir, a little comment that we had discussed about PLL, but the new WHO does not recognize PLL as the entity. So now it will go under either in the atypical CLL or in splenic lymphomas with prominent nucleoli.
Yeah, the diagnosis was always a problem because sometimes you look at the cells and you can't really make out whether you call it a PLL cell or not, and then what percentage was also kind of a little bit of a issue there. So yeah, this change is a recent one.
Another attendee has asked a question: how to report in a case of number of blasts more than 5% and less than 20% in a case of CML? Is it accelerated phase?
So now actually WHO says that accelerated phase, that term is not there.
Yes.
But I think our purpose is to communicate with the clinician. I'm sure ma'am will also agree with that. Whatever term we use, that means it's not just chronic phase. No, it's accelerated. I think we should mention and we should give a note. I mean, whether we follow ICC system or WHO system, still the debate is going on. I don't know how to.
I think it's better to follow the WHO till there is acceptance of the ICC. The only thing is that many times we don't have all the investigations in a given case to come to a definitive diagnosis. There, I think it's all right to give differential diagnosis and say that these additional tests are required to give a final diagnosis. I think that should be fair enough.
Yes. Also, I guess a flow cytometry in this case might help because if they're lymphoblasts, we are more likely to call it a blast phase because in that the percentage of the blast is discounted rather than the myeloid one.
Actually, a lot of comments there in the chat box.
Yes, the chat box was really active, and I guess all the attendees have really enjoyed. They were spot on. You were asking questions here, and the chat box was really active. So, the participants, would you like to ask any questions? If there are none, then I shall